Welcome back to Core Anesthesia. Whether you are a student prepping for tests and boards or a CRNA here to earn CEUs, we are glad you've joined us. For more about us, make sure to check us out on Instagram at Core Anesthesia and online at coreanesthesia.com.
Welcome back to Core Anesthesia. I'm Cole, here with Tanner, and today we're going to talk about perioperative neurologic complications. And we've done several episodes talking about various neurologic complications that there can be around anesthesia. Today we have just a miscellaneous conglomeration of some that we have not talked about yet. So we're going to start off talking about substance abuse and some of the different substances that patients can be on and how this will alter our anesthetic plan. Then we're going to move into dementia. We're going to talk about emergence delirium. We're going to talk about post-operative visual loss and then peripheral nerve injuries. And so Tanner, do you just want to start us off here by jumping into substance abuse, and we'll run through some of the various more commonly used substances that we could see with our anesthetic patients.
Yeah, and with these patients, ideally, this is something that we have information about before the day of surgery. Obviously, depending on what type of surgery or if the surgery is urgent or emergent, then many times you will not have the luxury of getting the patient history before and trying to come up with a plan prior to the day of surgery. But let's talk about like an elective case, and we're talking about something that we have a little bit of time to plan for. Ideally, we're evaluating these patients in a pre-anesthesia clinic, PAT clinic, or something like that. And then we can also look into their history to see if this is something with the substance abuse, that if it is a chronic abuse or if this is something that is acute substance abuse, is going to change how we really handle the anesthetic with these patients. If a patient comes in, let's say for their pre-anesthetic testing and they're suspected for substance abuse, then we'll want to get urinary drug screen to see exactly what we're dealing with, or if this is even something that needs to be addressed. If this is an elective case and patients show signs of acute substance abuse, then or acute intoxication, I should say, then we're going to cancel that case if it's an elective case. They can have impairment with the autonomic and cardiovascular systems, where we can have variances that would not be safe for the anesthetic, especially if it's an elective case. If it's an urgent or an emergent case and you can't reschedule this, then we need to try to come up with a plan that will be the safest for the patient. Really, something that we should think about is how we're going to manage the pain for these patients. Many times, if they have chronic substance use, they're going to be less tolerant to pain. So we need to try to figure out creative ways that we can manage their pain and try to, safely do this while we're ultimately most concerned about their safety. We also need to, be addressing their pain as well. If possible, regional anesthesia is going to be really helpful in these situations. Peripheral nerve blocks, or if you're doing a spinal or something like that, that's going to be very helpful to manage the pain. If we are not able to do that, or even if we are, we're going to want to be looking at adjuncts that we can use, such as Precedex or ketamine, or if we're using NSAIDs, just looking at a multimodal approach to managing the pain for these patients. Let's talk specifically about alcohol. This is something that we unfortunately see, not that uncommonly. And so it's something that we thought pertinent to discuss here. If we see somebody that has a drug overdose, oftentimes alcohol is associated with the other substance. Alcohol will typically hinder the autonomic nervous system. So you can see hypotension, you can see hypothermia, even a coma if the levels are high enough. Speaking of the levels, intoxication levels are defined as a blood alcohol concentration above 80 milligrams per deciliter. If you're around 100 milligrams per deciliter, then signs of vestibular and cerebral dysfunction occur as well. Respiratory depression is also seen as blood levels continue to rise, and this can even be fatal depending on how significant that respiratory depression is. If you have chronic excessive alcohol use, then this will allow patients to develop a tolerance to the alcohol, and the symptoms will actually be comparatively minimal for the amount of alcohol that these patients are drinking. It's important as we're going through their health history to understand, how much a patient is using alcohol, and also understanding the length of time that they've been using alcohol to try to get a better understanding of maybe their tolerance, and also we'll talk about anesthetic considerations, but we're talking about different physiological changes that will happen in the body that would accommodate their use of alcohol, but also will affect our anesthetic management. Many times you'll see patients that have alcohol use disorders on medications to try to reduce the heavy alcohol use. You can see them on naltrexone or disulfiram. Disulfiram will basically cause the unpleasant symptoms. You can see increased nausea, vomiting, even vertigo when alcohol is ingested. So this is something also, if you have a patient that has this on their history, to also be checking out their medication list to see if this is something that they're taking. If they're taking the naltrexone, it should be discontinued 72 hours before surgery. Naltrexone is an opioid antagonist and will limit the ability of opioids to provide the analgesia that's necessary during a procedure. So it's important that is to be discontinued, again, 72 hours prior to surgery. If they're receiving the naltrexone IM, then they should receive their last injection about 4 weeks ahead of the procedure. If the patient is receiving the disulfiram, then there is also sedation and hepatotoxicity that is associated with this medication. What this means for us is that basically we'll have a less anesthetic that is needed for these patients. It also limits the production of norepinephrine in the body. So there is an increased risk for hypotension when we are putting these patients under anesthesia. And so for these patients, since they have this basically down regulation or the decreased production, they're going to have an increased response to phenylephrine when we are giving these patients phenylephrine to manage their blood pressure compared to ephedrine. Remember that ephedrine also works with that secondary effect. And so if they don't have that endogenous norepinephrine, then it's not going to be as effective as when we're giving phenylephrine. One last thing I wanted to mention here, when we're talking mostly so far about chronic alcohol use, if somebody presents acutely intoxicated, then they're going to have a decreased MAC needed for sedation. If going back to chronic alcohol use, you're going to see an increased MAC for these patients because of the tolerance that's built up in their body systems. But again, if they're acutely intoxicated, then we're going to need less anesthetic to do the job for these patients.
So next, let's talk about cocaine. And cocaine is a sympathetic stimulant that's going to block the presynaptic uptake or reuptake of norepinephrine and dopamine. So this basically means that more of the neurotransmitters then are going to be present in the synapse that can transfer over and bind to the receptors on the postsynaptic membrane. The duration of action of cocaine is going to be about 30 to 60 minutes. So keep in mind that if you do have a patient that comes in with a cocaine overdose and you're going to be doing surgery on these patients, typically the effects of it are only going to be at the peak if we're doing like a rushed emergent surgery when they first come in. Typically after we wait a few hours to get a patient pre-op and ready to go and start the procedure, the peak effects should be past from this. So with an acute cocaine administration, it's going to cause coronary vasospasm, myocardial ischemia, and then myocardial infarction, which can lead to ventricular dysrhythmias. There's also going to be this, again, sympathetic stimulation. So you're going to see tachycardia, hypertension, and both of these together then are going to further increase the demand, specifically the oxygen demand on the heart. So if you can picture all these things working together here, it's going to make the heart have less oxygen supply and a greater demand for oxygen. So that is why we see an increased risk here for a myocardial infarction and then a ventricular dysrhythmia that can develop. So when a patient overdoses on cocaine, this can cause an uncontrolled hypertensive response that's going to result in pulmonary and cerebral edema, coronary artery vasoconstriction, and then we also can see platelet aggregation as well. So if a patient does come in with this, how we treat it is by giving nitroglycerin to manage the myocardial ischemia, and then alpha adrenergic blockers can be given to combat the coronary vasoconstriction and higher blood pressure. And then benzodiazepines can be given to control any type of seizures that may develop as well as a side effect of cocaine overdose. So as I said, if we're doing the procedure within the few hours where this is going to be peaking in the patient's body, so they come in, you're doing an emergent procedure on them. Acutely intoxicated cocaine patients are going to be more susceptible, as I mentioned, to the dysrhythmias and myocardial ischemia. So a lot of times we'll have nitroglycerin just ready and in the room to treat for any myocardial ischemia or tachycardia, hypertension that develops from these patients. We want to limit any additional medications that are going to further stimulate the sympathetic nervous system because it's already going to be highly agonized and stimulated. And then if regional anesthesia is needed, we need to verify that the platelet count has not dropped as a result from that cocaine overdose, because that cocaine overdose can cause that thrombocytopenia. So just know that if you have a lab value from the day before, 2 days before they have their platelet count, it's probably not going to be an accurate representation of what that platelet count is if they're acutely intoxicated with cocaine.
Next, let's talk about opioids. So patients that have chronic opioid use will develop a physical dependence on these opioids. It can happen even less than 14 days, really, that it takes to develop a dependence on opioids. If you see a patient that is overdosed with opioids, then you'll see typically a slow respiratory rate. They have very increased tidal volumes. Pupils, you will see meiosis. Pulmonary edema can develop. You can see dysphoria or unconsciousness as well. Think about when you're managing a patient, you get to the end of the case and you're giving them narcotics. You're working in maybe narcotics to the respiratory rate, and you get a patient really nice and comfortable. They're breathing 6 times a minute. You see that the breathing rate slows down. The breaths become very large tidal volumes. And so you can get a pretty clear picture, even from what we do to manage patients, to see what these patients would present as when they come in with opioid overdose. Naloxone is the opioid antagonist that we would give to reverse an opioid overdose. These patients that are using opioids chronically and have maybe a chronic opioid use disorder, then you can see them on different treatments for these. Withdrawal from chronic opioids is going to be very, very unpleasant. And so specifically, we think from an analgesic standpoint, he's taking medications for a specific issue typically. And so then withdrawal from that would be extremely uncomfortable and potentially dangerous and harmful for the patient. So many times they're placed on methadone, or you can also see buprenorphine, naloxone. That's a partial opioid agonist. And so these are medications that really are not that uncommon when we see these patients present to the OR for surgery, that this could be on their med history list. So what does this mean for us? What are some anesthetic considerations that we should think about? Patients that are on methadone or buprenorphine for treatment of chronic opioid use, we should continue these medications throughout the perioperative setting. It's important to think about that we should see even a 20 to 30% increase in acute opioid requirements day of surgery because of just the higher tolerance for opioids. So these are not the patients that you are trying to, go as minimal or as light on your narcotics as possible. They have a tolerance. They have already developed to opioids. So it's very important that we are trying to fill that gap and take care of them and manage their pain. We should also be really considering all the different adjuncts that we can use. So NSAIDs, ketamine, gabapentin, Precedex, they should all be considered to use. And also regional anesthesia, that'd be a really nice adjunct to be using for their pain as well. Something that's not going to be affected by their chronic opioid use. And so if we can use a multimodal approach here with using regional, using these adjuncts, and then also keeping in mind that we need to increase the amount of opioids that we're giving day of surgery.
So next, let's talk about amphetamines. And amphetamines are going to be a stimulant that stimulates the release of catecholamines to make a person more alert and suppress the rest and digest system. So you're going to suppress your appetite and things of that nature. Often these medications are prescribed for narcolepsy, attention deficit disorders, and significant depression. Now, long-term use of amphetamines can deplete the body's stores of catecholamines. And I'll get into that effect when we talk about anesthesia considerations more. Eventually here, as we keep moving through this, the acute overdose is going to cause anxiety, a psychotic state, hyperreflexia, hypertension, tachycardia, seizures that can develop. And treatment for this, if a patient comes in and they're shown to be overdosed on amphetamines, we're going to do a gastric lavage, give them activated charcoal. We're going to do phenothiazines, which can be given to antagonize the stimulation of the sympathetic system. And then we also give benzodiazepines to control any type of seizures that would develop as a side effect from the acute overdose. So for anesthetic considerations for these patients, first of all, what happens if you have a patient that comes in for a regular elective scheduled surgery and they're on a long-term amphetamine use? So maybe they have narcolepsy and they're taking amphetamines. So these patients then are going to have a reduced catecholamine store, as I mentioned earlier. So they're going to require, for one, less sedation. But two, as Tanner kind of mentioned earlier, ephedrine is not going to work as well as we typically would see in these patients. And that's because of that indirect effect where it's going to augment or stimulate the release of the body's natural stores of catecholamines. So ephedrine won't work as well. Phenylephrine is a great choice to use instead. And then surgery, if you have an acutely intoxicated patient with amphetamine use, they're going to exhibit hypertension, tachycardia, hyperthermia, and they're going to require a higher MAC level to achieve that sedation. These patients are also then going to be at a higher risk of intracranial hypertension and cardiac arrest. So again, we need to make sure that we have any alpha blockers, nitroglycerin, et cetera, that we can use to lower the blood pressure to prevent those life-altering levels of blood pressure.
All right, two more that we want to talk about here. The first one is hallucinogens. And so let's think about what this looks like when the patients present. We have visual, auditory, even tactile hallucinations that can last for anywhere from 8 to 12 hours typically. You can see these patients that are tachycardic. They can be hypertensive. Hyperthermia can also be seen. An overdose with these patients, you can see seizures, even apnea. Their moods can be unstable where you have basically panicked reactions or psychosis even. And so these are all things that we want to keep in mind if a patient presents with hallucinogens. With our anesthetic considerations, we should note these patients are going to have an exaggerated response to sympathomimetic drugs. Respiratory depressant drugs will have a prolonged duration of action, so we'll want to be very careful when we are waking these patients up and sending them over to PACU that we're very aware of any respiratory depressants that we're giving. If we have an issue with panic attacks, then it's very helpful to give Versed, benzo to help with those panic attacks. It's very important that these patients, they're experiencing very real things to them that we obviously are not experiencing. And so it's going to be something that's taking a lot of understanding on your part and also trying to think ahead of how you can best make these patients comfortable and try to minimize the effects that they're having from those hallucinogens. The last one we want to talk about here is cannabis. Chronic use of cannabis can increase the resting heart rate. You can also see that the patient's lungs will begin to develop these tar deposits, that you'll see decreased pulmonary function. You can also see bronchitis as well from chronic use of cannabis. You can also have patients that will present with seizures. If they're acutely intoxicated, you can have reddening, conjunctival reddening, drowsiness as well. And those would be more signs to show you that the patient is acutely, taking cannabis. Anesthetic considerations for these patients, the main thing that comes to mind, especially when we're talking about the different, physiological effects from cannabis, is really the lung compliance issue. And so if you have these patients that have been using this for a long time, then you can see really decreased pulmonary function, decreased lung compliance. And so this will be a consideration as we manage them for our anesthetic. Ketamine duration of action will be increased, something to keep in mind with these patients. You can also see an increased respiratory depression from opioids when you're caring for them. And so again, something to be alert and aware of, maybe helpful to go through some of the symptoms here so that we are aware if they're acutely intoxicated or if this is something that is just in their history. But again, important to bring all of that to mind when we're managing them in the OR.
So next, let's move on and shift gears, and we're going to talk about dementia, and then we're going to talk about emergence delirium. So specifically with dementia, this is a generic term used to describe when there is a loss of memory, problem-solving ability, and a decrease in language ability that is severe enough to interfere with daily life. And it's estimated that around 5 to 8% of the population age 60 and over have some level of dementia. So with this in mind, a lot of the geriatric patients that we take care of for anesthesia, you're going to have at least 1 in 20 of those, if not more, that come in with a baseline level of dementia to begin with. One of the earliest signs of dementia is going to be the intellectual decline, and any pre-existing dementia in a patient presenting for anesthesia is going to be a strong predictor of post-operative complications and an increased risk of 30-day mortality. So there's causes that are reversible for dementia and causes that are non-reversible. So the reversible causes include chronic drug intoxication, vitamin deficiencies, a subdural hematoma, hydrocephalus, and hypothyroidism. Some of the non-reversible dementia causes will include degenerative brain diseases. So an example of this would be Alzheimer's disease. So how do we manage this? So management of dementia includes, first of all, pharmacological therapy aimed to control behavioral problems with, let's say, agitation, sleep disorders, along with preventing further intellectual decline. So examples of medications that potentially these patients could be on would be vitamin supplements to replace the lower vitamin levels, N-methyl deaspirate, so NABDA antagonists, selective serotonin reuptake inhibitors, melatonin, and central acting acetylcholinesterase inhibitors. So how's this going to alter our plan? Let's say you're taking care of a 70-year-old patient who comes in, you do a preoperative assessment, and you note that they have dementia or some level of dementia. It's imperative that you document their level of neurological function and mental capacity prior to going to surgery, so we can compare their postoperative subjective assessment compared to their preoperative cognitive ability. Additionally, when we're doing that preoperative assessment, we need to ensure that they're even able to make an informed consent on their own in the preoperative setting. If not, the consent needs to be obtained by one of the family members or healthcare power of attorney. Again, we need to document that baseline cognitive and neurological function so that we can compare to it afterwards in the postoperative setting. And when we get to the postoperative setting, we need to treat postoperative pain and minimize sleep disturbances, as increased pain levels and an alteration in sleep are two of the risk factors that are going to increase that delirium effect in the postoperative setting. And then often, depending on the severity of the dementia, there's often a multidisciplinary collaboration that's involved with this whole process of perioperative environment. Often the family's involved, caregivers are involved. There's often a neurologic consultation, any of the bedside providers. So let's say it's an inpatient and we're going to be scheduling a procedure later in the week. We're going to have conversations with the bedside staff leading up to that about getting a normal sleep schedule involved, the pharmacological interventions that are being done. It's a very well-rounded multidisciplinary approach to be able to hopefully get that patient prepared and ready to go before the anesthetic in the day of surgery, so that when they wake up, they hopefully minimized any type of further decline or alterations that we could see in that disease process. So similarly, we have emergence delirium. This is different than simply dementia. Emergence delirium is a term used to describe an abnormal emergence from anesthesia that presents with aggression, agitation, and altered orientation. The patient may be hyperactive to the level or extent in which it places both the patient and any caregivers at a risk for safety. And delirium is separate from simply just agitation. So don't think it's simply the patient's extremely agitated when they wake up. It's separate from that. Agitation is defined as a mild restlessness or mental distress. This is going to be to a whole nother level of that, where they when they wake up, they just have this shift to where they're a very aggressive nature. Their orientation is off. Again, they're very hyperactive, etc. And emergence delirium is often going to be seen in healthy pediatric and younger adult patients, along with combat veterans. And the risk factors are going to include psychiatric disorders, preoperatively, psychiatric disorders, psychotropic medication use that the patients may be on, or substance abuse as well. So what are some things that help with this? Benzodiazepines have been related to adult emergence delirium, but not pediatric cases. So with this in mind, if you have a patient that comes in, maybe they say they did have a emergence delirium in a previous case, benzodiazepines have been associated with an increased risk of having that emergence delirium again. But in the pediatric patients, benzodiazepines will actually help and decrease that level of emergence delirium. However, though, in the pediatric population, sevoflurane has been associated with a greater emergence delirium. And that's often one of the main volatile anesthetics that we use for general cases for the pediatric population. So do keep in mind that you are going to have an increased association with that emergence delirium in the pediatric population. Now, other causes of emergence delirium are going to include pain levels. So if the patient wakes up and they're in a severe amount of pain, that's going to aid into the emergence delirium. If there's anxiety, so specifically with a child, separation anxiety from their parents. And if they have an abnormal temperature, either hypo or hyperthermia can also aid into the emergence delirium factor. So how do we treat this then? Well, it revolves around correcting the cause. So if the cause is pain, if the cause is anxiety, you might want to get a family member. The voice of a mother or a father goes a long way in resolving or limiting the emergence delirium. If they're in extreme pain, we want to give them analgesics and get that better under control. And now management overall in the perioperative experience to limit emergence delirium mainly focuses on the prevention and minimizing the risk factors to begin with. And preoperative education goes a long way in reducing the anxiety, specifically about where the patient is going to be when they wake up, that they might be in pain, that they're going to be a little altered with their mentation as they first become awake, and just educating them on that fact ahead of time goes leaps and bounds into limiting and reducing the anxiety when they do wake up and are experiencing that firsthand. If you know a patient has had a previous episode of emergence delirium, then they may be a candidate then for doing a total intravenous anesthetic, so a TIVA, rather than using sevoflurane. So you may do a drip of propofol throughout the case. Dexmedetomidine or Precedex has been shown to help perioperatively with anxiety and minimizing that emergence delirium. That is a drug that has become more well-versed with the pediatric population to give to reduce the anxiety and provide some analgesic with the alpha-2 receptor as well. So that is a great drug that kind of aids in both of those two causes. Low-dose ketamine on induction has been shown to decrease emergence agitation and postoperative pain as well. And then postoperatively remove anything from the body that's no longer needed. And this may seem obvious, but it goes a long way, such as Foley catheters, airway devices. If you leave a nasal trumpet or an oral airway in until they wake up enough, just simply having those extra devices in their body will aid into the amount of delirium that they're going to have when they wake up. Pain should also be treated, obviously, and we often will treat this with fentanyl, or we give dexmedetomidine or Precedex again in the postoperative setting. And then if the patient has ripped out their intravenous access, so this can happen a lot of times if the patient does wake up with this delirious state, they're agitated, they're hyperactive, and they rip out their intravenous access, then haloperidol, IM, or ketamine intranasally can be given. And then lastly, if potential causes such as pain, anxiety, hypoxia, if they've all been eliminated as potential causes, then patients can be resedated with propofol in order to, quote, reset them, so to speak, and wake them up a second time. So we'll titrate just enough propofol to cause the unconsciousness again, and then go ahead and reset and wake them back up.
All right, continuing on the perioperative neurological complications, we're going to pivot once again here and talk about postoperative vision loss. This is another complication that we can see, and it's important to talk through the different reasons why this can happen. What are things that we can do to try to attenuate this? Postoperative vision loss, you'll often see this just abbreviated as POVL. This is a rare complication typically, and it can develop even in non-ophthalmic surgery. It can range from a variety of things. It can be just decreased visual acuity to complete and total blindness on the other end of the spectrum there. We think of postoperative vision loss occurring from three main causes. So you can see ischemic optic neuropathy, you can see central retinal artery occlusion, or the third one is central retinal vein occlusion. So we'll go through and talk about what each of these look like, what causes them, and this will hopefully clear things up a little bit. Ischemic optic neuropathy is going to result when there's damage to the optic nerve due to hypoperfusion. Specifically, this is when you have a decreased ocular perfusion pressure, OPP. So how we calculate OPP is the difference between the mean arterial pressure, our MAP, and the intraocular pressure, the IOP. So to limit a decreased ocular perfusion pressure, again, OPP, is the main goal that we are trying to achieve, and we are trying to maintain their MAP. while minimizing the intraocular pressure. Typically, a drop in ocular perfusion pressure occurs when you have steep Trendelenburg or prone position. And this is mainly due to the limitation of the outflow of the venous blood from the eyes. And this is going to drastically increase the intraocular pressure. You can also understand that if you had a severe drop in your MAP, this is going to affect the other side of the equation. So again, if we're really concerned about the ocular perfusion pressure, what's really driving that is your MAP and your intraocular pressure. So you can see that this can either occur from a driving up of the intraocular pressure, which is typically due to your reduction in venous outflow, or you can see a massive decrease in your MAP, which would also cause that decrease in the OPP. The next cause that we want to talk about is central retinal artery occlusion, and this is caused by a decreased blood supply to the entire retina. Many times when we think of this is most often caused by improper head positioning that will put external pressure on the eyes. You can also see this from emboli, but typically we think of this more being from the external pressure on the eyes due to improper head positioning. Patients will usually have unilateral vision loss in the post-operative setting when they have this central retinal artery occlusion. The last one is central retinal vein occlusion syndrome. So this is when pressure builds up in the eye due to the venous system having a backup in pressure. So risk factors for this would be hypertension. If you have a patient that has really increased BMI, cardiovascular disease would also play a factor here. And then open angle glaucoma would also be something that would put you at risk for the central retinal vein occlusion. Many times, external pressure on the globe can cause central retinal vein obstruction. And then when the patient is in the prone position, this is really specifically where you can see this. So for this reason, patients are often immobilized with pins rather than resting their head on a horseshoe or a headrest when they need to be in this prone position for specific cases. Anesthetic considerations that we should think about. So the risk for postoperative vision loss should be explained to patients in the preoperative setting, especially if you have a case that is going to be really lengthy in time. And also if you maybe expect a high blood loss during the case, if you have a case where the patient's going to be prone or in steep Trendelenburg position, these are all going to be risk factors that it's imperative that we're talking to the patients about the postoperative vision loss. While we're actually back there doing the procedure, it's important, obviously, that we avoid direct pressure on the eyes, pressure around the globe, especially longer prone procedures. You want to make sure that you're checking the pillow, making sure that nothing is causing direct pressure there onto the eyes. You want to make sure that you try to avoid venous occlusion by keeping the head in a neutral position. You don't want to have any reduction in outflow, which would cause these issues. If you have cervical flexion, again, that can cause a diminished venous outflow, creating this problem. You really want to avoid the horseshoe adapter for patients in the prone position. The pillows that have been developed are now the preferred technique here. So the pillows that have the cutouts for the eyes, nose, mouth, that's what's going to be more preferred than these horseshoe adapters. Again, in patients that have an increased risk for postoperative vision loss, then we really want to avoid any hypotensive scenarios that we're going to be changing that. Remember that equation is going to be your MAP minus your intraocular pressure. And so we're going to want to make sure we're keeping blood pressure up. We're not causing any perfusion issues there with the OPP.
So lastly, let's talk about peripheral nerve injuries. And this is a wide topic in itself. So again, we're just going to hit some of the overarching themes here. And I'm going to first talk about some of the nerve injuries, and then we'll go into positioning and how we limit any type of nerve injury that could develop from those unique positions. So first, let's talk about ulnar nerve injury. Ulnar injury can occur due to external compression of a pull on an arm or an excessive elbow flexion due to pinching the nerve at the olecranon process. So in that backside of the elbow is where that nerve comes superficial, and so it's more likely to be damaged there. So just think about if you ever bump the back of your elbow on something and you have the electric shock sensation that goes down your arm and you become numb closer to your pinky finger and second finger as well, or that'd be the fourth finger. That ulnar nerve getting stimulated there. So we're a lot more at risk of having injury to that spot, especially in the back of the elbow there where it comes to the superficial side. What's this going to result in? It's going to result in the inability to abduct or oppose the pinky finger and an impaired sensation of the fourth and fifth digit. So as I talked about how you kind of have that sensation or tingliness when you do hit the back of your elbow on something. If this is prolonged, though, the atrophy from the intrinsic muscles of the hand will cause this claw-like contracture. So often that is a signature position change of the hand that we relate an ulnar nerve injury to. To prevent ulnar nerve injuries, then, we need to make sure we're patting the patient's arms while maintaining the arms in a supinated or a neutral forearm position. So again, supinated are going to be palms up, and then neutral will be where the palms are facing in towards the body as the arm is vertical. You want to keep the arms abducted less than 90 degrees at the shoulder, less than 90 degrees there. If we do pronate the arm, it's going to increase pressure over the ulnar nerve. So that's why we stay away from pronation. And that'll be when you have your palms down. When the arms are tucked, as I mentioned, the arms should be in the neutral position with the palms facing towards the body. So if you have the arms out on an arm board, you're going to want them palms up. If you have the arms tucked at the sides, you want them neutral with the palms facing into the body. Next, we have median nerve injury, and this is not as common, but it can happen with elbow hyperextension. If you place an IV in the AC, you're at risk for damaging the median nerve injury, or any type of carpal tunnel syndrome due to the nerve passing through the carpal tunnel. And it's going to present as the inability to oppose the thumb, a reduced feeling on the palmar side of the thumb, the index finger, middle finger, and lateral side of the ring finger. We also have radial nerve injury that can occur, and this radial nerve will pass on the lateral side of the humerus, meaning that if you have any external compression from a pull, you're at risk for causing injury to this nerve. Additionally, excessive blood pressure cuff compression throughout, let's say you have a 4 or 5 hour case, and every 2 to 3 minutes, you're squeezing the arm with a blood pressure cuff. You're going to risk damaging this nerve and causing injury as well. And this will result in the inability to extend the hand at the wrist. So the fingers will, in essence, just fall downward when the palm is facing down. You can also have a sural nerve injury, and this is on the underside of the leg. So often this can be injured with pressure to the lower side of the calf. In the lower extremity, keeping some other nerves in order, superficial peroneal injury is a nerve that runs on the top of the lower extremity. And so pressure on the top of the leg can cause injury here. So I often think when you're looking at sural injuries and superficial peroneal injuries, if you're somebody who crosses your legs, then the top leg, the superficial leg, the underside of that leg will be putting pressure with the top side of your lower leg. And so the sural nerve on the top leg will be at risk for being injured, and the superficial peroneal nerve on the lower leg, because it's on the top of that, will be compressed and be at risk for being injured. And then a couple more here. You have the obturator nerve injury, and this will result from excessive flexion of the thigh towards the groin, and it will result in the inability to adduct the leg. And then you also cannot sense the medial aspect of the thigh. And you also can have a femoral nerve injury, and this is due to an excessive traction of the leg, and it will result in an impaired hip flexion and knee extension. So if you think about somebody taking their leg straight and trying to lift it while they're laying flat on their back, lifting their leg straight up in the air, they're not going to be able to, for one, hold that knee extended straight, and then two, they're not going to be able to flex that leg up at the hip. It'll also result in a reduced sensation over the anterior aspect of the thigh and the anteromedial aspect of the leg. We also have sciatic nerve injury, and this is caused from an extreme hip flexion and external rotation of the legs, or simply from sitting with a straight leg for too long. And it'll present as a foot drop. And then lastly, we have pudendal injuries and pudendal nerve injuries. And this is going to be when the groin is compressed against a peroneal post, and it presents as a loss of penile sensation or crushed injury to the genitalia. So next, let's end by just talking about some of the different position changes and when these nerve injuries can occur with each position that we're in. The most common position for a surgical procedure is going to be the supine position. This is where the patient is lying on their back, flat on the bed. And it's important that we keep their shoulders in this position. If they're going to be out on an arm board, we keep them abducted less than 90 degrees. And this is going to limit any brachial plexus nerve injury due to the head of the humerus being pushed into the axilla in this position if we do go past that 90 degrees. The brachial plexus injury can occur in almost every patient position that we talk about here, especially then if the arms are going to be abducted more than 90 degrees or if the head is rotated to the side. Because then you can cause a stretch injury from the shoulder to where the head is turning away of that brachial plexus. So in the supine position, again, if we abduct the arms greater than 90 degrees, we're going to cause a stretch injury of the brachial plexus around the humeral head. And then if we turn the head to the side, it can also cause a stretch injury. And then it can also, on the contralateral side, compress that brachial plexus. So you're at risk for both in that case. And then we also, as I mentioned before, if we're going to have the arms out, we want to keep them supinated, palm upward, or have them neutral with the arms tucked against the body to limit that ulnar injury. So next, let's talk about Trendelenburg position. And this position is going to involve placing the patient head down with the legs up. So again, this is keeping the patient straight and flat, but you're now tilting them on their head, so to speak. And if the patient slides potentially downwards further throughout the case towards the head, there could be a stretch injury on the brachial plexus. And this is because we often try to keep the body in place. And so we often will use shoulder braces. They can be placed to prevent the patient from sliding towards the head even more throughout the case. And if these shoulder braces are not placed correctly, you're going to be able to have that stretch injury to the brachial plexus. So how do you do this correctly? So if you're going to be using shoulder braces, they should be placed over the acromioclavicular joint. And if they're placed too medial, they can cause external compression of the brachial plexus itself. But if you place it too lateral, it can cause a stretch injury to the brachial plexus. So keep in mind that when you do put a position in this position, the shoulder braces are key to making sure they're aligned appropriately.
On the flip side from that position, we have the reverse Trendelenburg position. And think about the different things that we just talked about with Trendelenburg position. There's some similarities and differences here when we talk about reverse Trendelenburg. So again, this is opposite. So we're going to be raising the head while lowering the legs. Table straps are often used for the patient to prevent them from sliding to the foot of the bed. There have been some cases, however, that the patient does start to slide. These straps are too tight, and then you get some lower extremity neuropathies because of these straps causing constriction and causing compression there on the lower extremities. A footboard is recommended over the extreme tightening of the straps. And then oftentimes too, you'll be using the pink padding that is going to help prevent the patient from sliding on the operating table. The next position that we are going to talk about is what I would consider kind of a landmine of different potential injuries or potential risks here. And I guess it's a good reminder to think about all these different positions, that they all have their unique risks for positioning injury. Many times we kind of get into a slump of just thinking of certain ones or the obvious ones. It's important as we go through each of these to be just reminded, but this is definitely one that we need to be paying very special attention to all the different pressure points as you have more of them here in the lithotomy position. So lithotomy position, you have the legs up in the air, hips are going to be abducted in the stirrups, abducted ABD. And so you can see that you have these patients being, their legs being raised and lowered at different times, beginning of the case, end of the case. And this is just one scenario that we need to be very careful when we are having this occur during the case. Make sure that the legs are moved together. If this is not done together, you can have issues with spine torsion, moving one leg at a time. Lots of times we get into a rush, or the room gets into a rush, and the people that are positioning the patient may just go to do one at a time. It's very important that it's our job to keep the patient safe, maintain proper positioning. And so we need to be advocates here to raise and lower the legs together. Finger injury is another one that should be very, very closely monitored. Think about when you have the lower part of the bed off, the patient's legs are up in these stirrups, and the patient's hands are on arm boards or they're tucked right next to their body. When the foot portion of the bed is being placed back onto the bed, It's extremely important that you do a quick check and make sure that the hands are free and clear and that they're not going to be sliding that foot portion back on, or you're not going to be raising the foot portion up. Many times you're using the remote to just raise the lower part of the bed up. And if you're not checking those hands and those fingers, then this can be a very nasty crush injury to the hands and fingers. Another injury that we should think about is the common peroneal nerve injury from the lateral leg compression against the bar or the leg strap, whatever is being used in the stirrups. This will present as foot drop and the inability to extend the toes dorsally. And again, this is important that we have padding here, making sure there's not too much pressure there on the common peroneal nerve. If we have any compression from the bar or leg strap on the medial lower leg, then you can see issues with the saphenous nerve injury there. This is going to present differently compared to that foot drop and inability to extend the toes dorsally that we see with the common peroneal nerve. This will show as reduced sensation over the anteromedial aspect of the leg. One more that I want to talk about is the sciatic nerve injury. And we're so focused on the anterior aspect, and we have, where we have compression or potential pressure from the stirrups, or, just watching for the hands when we're putting on the legs, on the leg portion of the table. There's a potential here that you can have external rotation in the hyperflexion of the hip that would cause that sciatic stretch injury there for the patient. The other thing is that you can see obturator nerve injury because of the excessive flexion of the thigh to the groin. And so this would be there on the front side of the patient where you can see sciatic. On the back side, obturator nerve is going to also be at risk here because of that excessive flexion.
So next, let's talk about the lateral position. And this is when the patient is going to be on their side and the dependent leg is hopefully going to be flexed here. That's what we want to do. We want to take their lower leg, flex it up, and a pillow or padding should be placed between the knees of the two legs. And the dependent arm should also be placed in front of the patient on a padded arm board. And then the non-dependent arm is going to be supported by pillows or blankets or with a padded armrest as well. An axillary roll is usually placed underneath the patient, caudal to the axilla and not in the axilla. It's very important. We want it caudal to the axilla because if it is placed up in the axilla, it'll actually prevent blood flow from flowing down the arm and cause an injury there to the brachial plexus as well. But the purpose of placing this axillary roll is to prevent the compression injury due to the brachial plexus and the axillary vascular structure on that dependent side being compressed together. So there is purpose in placing that, but we need to place it correctly. Otherwise, we do ourselves more harm than good. Injury to the brachial plexus can occur in the lateral decubitus position if there is any type of lateral rotation of the neck, or if you stretch that brachial plexus, or if the arm is abducted greater than that 90 degrees. And so remember, pretty much in all of these positions, you never want to abduct greater than 90 degrees. Otherwise, you're going to cause injury to the brachial plexus from it rotating around that humeral head. Additionally, one of the ways that you can verify that you're not causing too much compression in the dependent arm is by placing, if you're going to do an invasive art line, placing it on the dependent arm, usually in the radial part of that arm. And that is going to be used to detect then any neurovascular compression from the axilla or in the axilla. And additionally, you can put a pulse ox on this dependent finger to monitor for ischemia as well to that extremity. And then lastly, we want to keep the head and the neck in the neutral position and prevent folding or excessive pressure on the dependent ear, avoid external compression on the dependent eye. Again, all these things, you want to make sure that we're padding appropriately and we're assessing throughout the case to make sure that we don't have too much pressure build up there. It can cause injury. The next position is the prone position, and this is when the patient is going to have their head, as Tanner talked about, specifically with the post-op visual loss. They're going to be at risk here of having that post-operative visual loss. And so when they're in the prone position, they're going to be their head down, and their legs should be padded and flexed slightly at the hips and the knees. And the arms can be positioned tucked at the patient's side, or they can be on an arm board and next to the patient's head with their arms extending above their head. But again, we want to make sure that we're not abducting their arms greater than 90 degrees at the shoulder to limit any injury to the brachial plexus. If the shoulders are not supported, they potentially will sag anteriorly throughout the case and create traction and stretch to brachial plexus again. And then an ideal placement of the bolsters that are going to be underneath their abdominal region in the prone position. The ideal placement here is going to be from the clavicle to the iliac crest. And this is going to reduce any abdominal compression and its effect on the lungs, the inferior vena cava. It'll minimize the decreases in pulmonary compliance, venous return. But again, these bolsters should be placed between the clavicle and the iliac crest. They shouldn't go beyond the iliac crest in order to protect the genitalia and the femoral vessels from being compressed here. And then additionally, the abdomen and the breast should be placed medial to the bolsters in order to be free of any of the compression then from them as well. And then lastly, any bony prominences of the face, the forehead, chin are at risk for compression and pressure injury during this prone position. And so as Tanner talked about earlier, the most commonly used or recommended used device here is the foam pillows with the slits cut out for the eyes, the mouth, etc.
The last position we're going to talk about here is the sitting position. This can be used for surgical procedures involving the superior cervical spine and the posterior fossa. A modified sitting position or beach chair position is often used for shoulder surgery. This is probably more common when you're thinking of the sitting position or the beach chair position. Things to consider here, we want the arms neutral at the patient's sides. The shoulders should be even or even a touch elevated to prevent that stretch injury between the neck and shoulders. This is the same stretch injury that we're concerned about when the patient's prone and we're putting in that extra padding to make sure that those shoulders are not just hanging dependently. Same thing here, we don't want to have any increased stretch there in the shoulder region. So make sure that those arm boards are high enough to keep their shoulders level or maybe even a little bit elevated. You want to slightly flex the patient's knees to prevent a stretch injury of the sciatic nerve. Again, we talked about that with the lithotomy position, that you do not want to have too much stretch there from the lower extremities there through the back that would cause injury there to the sciatic nerve. And so that's something to consider. Have a little bit of bend there in the knees. Many times you can use a pillow or a specific ramp device that will keep the knees bent. And this will, again, prevent that risk of the sciatic nerve injury. Hopefully this is helpful when you're considering the perioperative neurological complications that you can see for our patients. I know that we covered a really wide range tonight, going from positioning all the way to dementia, talking about opioid use and other substances. And so we covered a lot of material tonight, but hopefully this is helpful to you as you consider the many things that we need to be paying attention to and trying to address to take the best care for our patients.